Good morning, everyone, and thank you to Hormone India, Dr. Mayur Agrawal and his team for inviting me for this very important talk. In fact, if I look at the people who are going to talk after me, I'm actually quite delighted to be considered in the same group as these legendary people. So today I'm going to talk to you about role of C-peptide in routine practice. I'm going to stick to a lot of practical aspects of use of C-peptide, some things which you will be able to use in your practice right from tomorrow. So a very important thing which I would like to say before we begin, and that is, if you see some of the people who are going to talk after me, like I said, they're absolute legends in their field. I'm of course not even 1% of that, but there's a legacy I would like to leave behind. And that legacy is that of computational thinking in medicine. Now, what we all do and what we all have been taught is that in medicine, 1 plus 1 is not equal to 2. I want to change this mindset. In medicine, 1 plus 1 is equal to 2. But you need to know what one you need to add with another one. So that is one step towards that. And with the use of C-peptide, we are going to go one step towards computational thinking. That is thinking in terms of numerics, thinking in terms of mathematics, thinking in terms of an algorithm, which improves the lives of patients. So that is what my entire talk is going to be a lot about. So let's start with a case capsule. Now, this is a patient who came to me. The patient is a 30-year-old male. He had osmotic symptom at the time of presentation and had severe hyperglycemia with random sugars of more than 600. His HbA1c was 14%. Now he was admitted because of the very high sugar, and we started this patient on IV insulin, but the GAD antibody was negative at the time of admission. Now, at this point of time, we did not do the C-peptide. I'll tell you in the presentation later why. We discharged the patient on basal bolus insulin, presuming that since the patient had ketosis, patient is likely to have type 1 diabetes. Now he comes back after a couple of weeks with a better glycemic control, and currently there is no evidence suggestive of ketosis. So now let's look at what is the next step. The question we all have in our mind is this: is this patient having type 1 diabetes? Is this patient having type 2 diabetes? Is he having LADA? Is it something else? That is what we are going to try to answer by the end of this presentation. So to answer this question for this patient at this point of time, we did something known as a mixed meal stimulation test. I'll tell you the process for mixed meal stimulation test, and I'll also tell you the interpretation, but right now focus on the results. So here the patient's C-peptide value at the time of fasting was 0.15 nanogram per ml. Please look at the units very carefully. And his corresponding blood sugar was 114. And post stimulation, post mixed meal stimulation at 90 minutes, his C-peptide was 0.5 with a corresponding value of sugar of 288. Again, I'll tell you the interpretation of this in a few minutes. Now, we are trying to develop a automated system. Like I said, the concept of 1 plus 1 is equal to 2 is what we are trying to develop. And in that regards, we have developed one very useful module for diabetes management, and that is what is known as the diabetology.co.in. So if you're interested in this project and would like to contribute more, send me an email and I would be happy to share the details of the same. Here I'm going to show you how we can enter the data of this patient and get more details about what we are dealing with. Right now, there will be some bugs in the system, so I urge you to have patience. We are trying to resolve some of the bugs. I'll in fact show you one bug which we found out while recording this presentation. But here is what I'm trying to show to you. Okay, so this is a patient. Let's put in the details of this patient in this module which we have developed. So this is a 30-year-old patient. I'll quickly go through the other things, right? What I want to really show you is what happens when we enter all the data. So assume we have entered all the data. Now here we entered the C-peptide value. It's nanogram per ml. This is the bug I'm talking about, right? It's nanogram per ml. So we changed this, entered 0.15 and 0.50 here, right? The fasting and the stimulated C-peptide values, right? And then when you enter all the data, right, after that you click on get recommendation in the bottom. Right, so you click here, you get, so this is where you get the output. So first thing it will tell you is the cluster classification. Now you're going to hear from Dr. Yajnik about subclassifying diabetes. And one method of subclassifying diabetes which has been suggested by Dr. V. Mohan is the Indian clusters for diabetes mellitus. And this patient falls into what is known as a severe insulin deficient diabetes cluster or cluster 1. And the output also suggests that this patient obviously needs insulin. And there is a mixed meal stimulation score which we have developed where the value is 10. So this value more than 10 is suggestive of an absolute insulin deficiency. Right? I'll talk about all of these points in more detail as we go along. Now, let's start with the core topic which we are discussing today. And the core topic is what exactly is C-peptide and how do you use that in clinical practice? Now, as you can see from this picture, there is something called as a proinsulin, which is secreted by the pancreatic beta cell. This is converted to a proinsulin. Now, a proinsulin is split into two parts. One is the actual insulin molecule, which has the alpha and the beta chain. And the second molecule is the C-peptide. Now, C-peptide is released in equimolar concentration as insulin. What do you mean by equimolar concentration? That means for every unit of insulin that is released, there is 1 unit of C-peptide that is also released along with that. So that is what we mean by equimolar concentration. So that means that amount of insulin and amount of C-peptide should be the same in the human body. Interestingly, that is not the fact. But before that, let's talk about the units again. Now, when we measure C-peptide, you can measure in two ways. Either you measure it using nanogram per ml or you measure using nanomoles per liter. How do you convert this? You need to first talk to your lab what results are being given to you. Our lab gives the values in nanogram per ml. So rest of my presentation, I'm going to talk about nanogram per ml and not nanomole per liter. But I understand some of the labs may be giving results in form of nanomoles per liter. So you need to interpret the results based on how your labs are going to give you. And I'm going to tell you how to convert this. So nanomoles per liter is equal to, or C-peptide in nanomoles per liter is equal to 0.33 into nanograms per ml. And the alternate conversion is nanogram per ml is equal to nanomoles per liter into 3. Right? So this is a very simple rubric for you to consider the conversion. Right? Now, how do you test for the C-peptide assay? C-peptide assay is collected using a EDTA sample, EDTA. And if you are using EDTA, the lavender color bottle, it is stable for 24 hours. So you can assess up to 24 hours, it is stable. However, if you collect this in a plain tube, then the levels start reducing after 6 hours. So you need to assay this within 6 hours. So this is something which is very important for you to understand while you are collecting the sample. Now, when do you test for C-peptide? Broadly, there are two reasons why you should test for C-peptide. One is the measurement of the insulin secretory capacity or insulin secretory reserve of the patients with diabetes. Basically, what I'm trying to say is to differentiate between type 1 and type 2 diabetes. And this is what we'll be discussing in more detail in the rest of the presentation. And secondly, it is also very useful in distinguishing insulin-dependent hypoglycemia from insulin-independent hypoglycemia. We'll not be discussing this in detail because hypoglycemia itself is a topic. And some of you who are following our YouTube Endocrinology India channel, we have a talk on assessment for hypoglycemia, non-diabetic causes of hypoglycemia for physicians. So you can see this video at a later date. Okay, so why is measuring C-peptide better than measuring insulin itself? I told you that insulin and C-peptide are released in equimolar concentration in the body. Then you would be telling me that if both of them are released in equal quantity, why would I not measure why would I not directly measure insulin and why would I waste my time measuring C-peptide? Well, this is the reason why I'm going to tell you. First and foremost, C-peptide has a longer half-life compared to insulin. C-peptide has a half-life of 30 minutes, whereas insulin has a half-life of just 5 minutes. Secondly, it has negligible extraction from the liver. Now, if you understand the dynamics of insulin, you understand that insulin, a lot of it has first-pass metabolism and it is extracted by the liver. Whereas C-peptide is not extracted by the liver, it has negligible extraction from the liver. Thirdly, it has a constant peripheral clearance, which is very easy to predict. Finally, the circulation amount of C-peptide is 5 times that of insulin, so it is much more accurate to measure. When you are trying to measure something in more quantity, it is much easier than to measure something which is in small quantity. And very importantly, the values are not dependent on exogenous insulin use. I've seen a lot of pediatricians especially trying to prove to their children that they have type 1 diabetes by measuring insulin levels. and they often fall short of this. If you're trying to differentiate between type 1 and type 2 diabetes, do not measure insulin level. Do not measure insulin level. What you need to measure is C-peptide. And remember, when you're measuring insulin, the insulin which you measure cannot differentiate between insulin you're given exogenously versus the endogenous insulin secretion, and hence measurement of insulin is fallacious. It should not be done for differentiating type 1 from type 2 diabetes. Okay, so what are the conditions before you should consider while testing for C-peptide? Now, if you're doing a fasting C-peptide or a mixed meal stimulation test, the patient needs to have at least 8 to 12 hours of overnight fast. The patient should have reasonable euglycemia. I'll tell this point again at a later time, but the point is that do not measure C-peptide when the patient is in a state of glucotoxicity. For example, I told you the first case. That patient would be classified as having perhaps insulin deficiency, but we did not measure the C-peptide when the patient came with blood sugars of 600. We measured the C-peptide when the patient had reasonable euglycemia. Thirdly, and very importantly, you should stop any insulin secretagogues that the patient has been taking, for example, sulfonylureas or ripaglinide, at least for 4 half-lives. And remember, if you stop sulfonylurea, sometimes the blood sugar can go up, in which case you may have to use insulin from outside. There is no harm in using insulin, right? But remember, you are testing in the morning fasting, so it's better you test before the patient takes his breakfast naturally, and hence the patient would not have taken the short-acting insulin in the morning. But if you are given a basal insulin at night time, generally it is fine, except for one small catch, which I'll come to in a minute, right? So if patient can be on insulin while you measure the C-peptide, like I said, the use of insulin will not impact the C-peptide measurement. Exogenous insulin will not impact the C-peptide measurement, right? Let me reiterate this point again. Remember, you have the pancreatic beta cell releasing insulin and C-peptide. Now, if you're giving insulin from outside, the insulin which you're giving from outside will also be measured by the insulin assay. But the insulin you're giving out from outside does not have C-peptide, remember. So whatever C-peptide you're measuring is endogenous. That is what the body is producing, right? The amount of insulin produced by body is a better measure. C-peptide is a better measure of the same. Okay, now how do you measure the C-peptide? So we already told you that these are the ways in which you collect the sample, but C-peptide can be measured in the blood or in the urine. When you measure the C-peptide in the blood, you can measure it as a fasting sample, as a stimulated C-peptide, and as a random C-peptide. All the three have some importance in clinical practice. And the other way of measuring C-peptide is urine C-peptide, where you can do a 24-hour urine correction, or there's another way of measuring C-peptide in the urine as well, which is developed by Exeter, which I'll come to. Okay, so what is the gold standard for measuring beta cell reserve? What is the gold standard of differentiating a patient, whether the patient is having type 1 or type 2 diabetes? And the answer to this, if this is asked as an MCQ, it is stimulated C-peptide. Stimulated C-peptide is the gold standard for measurement of insulin beta cell secretory capacity. Right. So how do you do the stimulation? Now the stimulation can be done using glucose load. So you can give 75 grams of glucose and you can do the glucose load. But a better way is mixed meal stimulation test, which I'll tell you the procedure. And another way, which is also standardized, is glucagon stimulated C-peptide, and I'll tell you the procedure for that as well. So these are the three ways in which you can do the stimulation test. Now, glucose stimulation, glucose load stimulation, we do not do in clinical practice because it is often erroneous. So it is either you do a mixed meal stimulation or a glucagon stimulation for stimulation of the practice. Right. Now, broadly, how do you differentiate type 1 and type 2? In type 1, there is little or no increase in C-peptide over baseline on stimulation. Whereas in type 2, there is some increase of C-peptide over baseline. So this is the key fundamental point which you have to understand. Now, let's look at a basal C-peptide value and whether a basal C-peptide value or a fasting C-peptide value is helpful in differentiating type 1 from type 2. To some extent, yes, there are some issues with this, which I'll come to. But if the basal C-peptide or the fasting C-peptide is less than 0.6 nanogram per ml, it is very likely, 80% likely, suggestive of type 1 diabetes. Similarly, if the patient has C-peptide value which is stimulated less than 3 nanogram per ml, again it is suggestive of type 1 diabetes. Okay, again let me reiterate this point. So if the C-peptide value, you can see fasting is less than 0.6 nanogram per ml, it is likely to be type 1. And if it is post-stimulation less than 3 nanogram per ml, again 80% likely that you are dealing with type 1 diabetes. Now, I told you that apart from the C-peptide mixed meal stimulation, you can also do a random C-peptide. So a patient comes to your OPD, does not have time for doing a fasting or a stimulated C-peptide. You can do a random C-peptide. And there's in fact one study which has shown that in fact random C-peptide is better, if not as good as measuring fasting and stimulated C-peptide. So there's a little hack, right? You can actually measure random C-peptide and get good interpretation from this without doing a stimulated test. But there is a catch which I'll come to. Okay, so how do you interpret a random C-peptide? Now, it is very, very important that when you measure the random C-peptide, right, this is the point I would like to really make. It is very, very important that you simultaneously measure the glucose value in the lab. So if you are trying to interpret a random C-peptide, a simultaneous glucose is necessary. Why is simultaneous glucose measurement necessary? Because of two reasons. One, let's say you do a random C-peptide, right, and the patient is having hypoglycemia at that point of time. What will happen when the patient has hypoglycemia? The endogenous insulin production will reduce. And because the endogenous insulin production will reduce, the patient will have low C-peptide, which will give you false low value. So it is very important that you simultaneously measure and send the glucose sample as well when you are measuring the random C-peptide. And secondly, interpret the random C-peptide only if the simultaneous glucose measurement is more than 140 milligram per deciliter. So do not try and interpret the random C-peptide value. If required, you may repeat the test, but do not interpret the random C-peptide if the glucose value is less than, simultaneous glucose value is less than 140. This is very important, right? So your simultaneous glucose measurement, the simultaneous glucose value should be more than 140 when you are trying to measure the simultaneous C-peptide value, right? So if this is not possible in your practice, then it is better to do a stimulated test. But if you do a random C-peptide, then these conditions are necessary. Now, how do you interpret a random C-peptide? So let's say a patient walks into my OPD and patient wants to know whether they have type 1 or type 2 diabetes. The patient has reasonable euglycemia, patient is on basal bolus insulin, and patient has maintained reasonable amount of blood glucose. What do I mean by reasonable amount of blood glucose? So again, typically a blood glucose between 140, a random glucose between 140 to 200 is a good time to measure a random C-peptide, right? So what I do in practice is that if I want to measure a C-peptide, first I use a glucometer and ensure that the patient's blood glucose at that point of time is between these values. And if it is there, then I send the patient to the lab for measuring the simultaneous RBS and the C-peptide, right? If it is not, then I would rather wait or do a stimulated C-peptide test to make the interpretation, right? So this is what I typically do in my practice, a little hack from my side, right? So let's say the patient's blood glucose is 180 milligram per deciliter, which I randomly measure in my outpatient, and then I send the patient to the lab and I send a random sugar. Even if you're done using a glucometer, you still send a lab sugar. So you send a random sugar using the from the lab along with the C-peptide, right? Now, if the C-peptide value is less than 0.6 nanogram per ml in a random sample, it is very likely to suggest type 1 diabetes or absolute insulin deficiency. And if it is more than 3 nanogram per ml, it is very likely to suggest a type 2 or possibly a MODY, right? So this is a very, very important, useful tool to use. So once again, let me repeat, and this is, if you do not take anything else from the previous lecture, this is what you should perhaps take. Let's say a patient comes to you and you want to differentiate type 1 from type 2 diabetes. The simplest way of doing this is first, step 1, measure the random sugar using a glucometer. If the random sugar is 140 to 200 milligram per deciliter, in that case, send the patient for a random blood sugar, RBS from the lab, and a random C-peptide. Now, when you get this value, if the value is less than 0.6 nanogram per ml, the patient has absolute insulin deficiency, likely to be type 1. And if the value is more than 3 nanogram per ml, in that case, the patient is unlikely to have type 1 and more likely to have type 2 or MODY. If the value is somewhere in between 0.6 to 3, in that situation, you need to repeat the test using the mixed meal stimulation test. I hope this fundamental algorithm is clear to you. Okay. Now, one clinical criteria developed for MODY, right? And this is a common issue, that does my patient have type 1 diabetes or MODY? Apart from type 1 and type 2, there's also, we need to differentiate type 1 from MODY. Well, what you have to understand, just like type 2, MODY patients also have preserved C-peptide. So there is something called rule of 3 for MODY diagnosis. Rule of 3 is age should be less than 30 years. There should be 3-generation family history. You're trying to do this 3 years from diagnosis, right? Why this is important? Because sometimes what happens is that the patient is done, the diagnosis is done too close to the time of diagnosis. Patient often may be glucotoxic, and in that case, you may not get a good interpretation. And in such cases, if the random C-peptide is more than 0.6 nanogram per ml, it is more likely to suggest MODY, right? But again, you need to be careful that your blood sugar should be between, simultaneous blood glucose should be between 140 to 200. Okay, so this is one criteria which was published in some study, right? Not that you follow this alone, right? But this is one thing which can be potentially helpful, right? Now, I told you that you measure the random C-peptide. Why not fasting C-peptide? Well, fasting C-peptide sometimes can have problem, right? So remember, fasting C-peptide, the blood glucose values are often would be assuming that the patient is having a reasonable blood sugar control. The blood glucose values will often be less than 140. Patient might have taken a basal insulin a day prior, and because of that, often the patient may have hypoglycemia. And hence, isolated interpretation of fasting C-peptide in the context of trying to differentiate type 1 from type 2 may often be erroneous, and sometimes the value is very difficult to interpret. Okay, so this point we already talked about, right? So a differentiating factor between a good physician versus somebody who has not attended this lecture is that whenever you send a random C-peptide value, also always send a random blood sugar along with that to the lab. And if you do this, you are somebody who has listened to this lecture and has made the right interpretation. Then let's talk about the glucagon stimulated C-peptide. So if you want to do a stimulation, I told you there are two basic ways of doing a stimulated test. Either you can do a glucagon stimulated C-peptide, or you can do a mixed meal stimulated C-peptide. In a glucagon stimulated C-peptide, you draw the baseline fasting sample. So you do a fasting sample. After that, you give 1 milligram of glucagon intravenously. And then after that, you take additional samples at 6 minutes and 10 minutes post the glucagon stimulation. So this is the glucagon stimulated C-peptide. Glucagon is available in India as an injection. Unfortunately, it's not easily available, but it can be potentially available. So you can, it is available from Novo Nordisk. Also, it is available from some independent companies as well, which manufacture glucagon. So if you need glucagon, you can procure that in India. It's not impossible. Okay. What about mixed meal stimulation test? So apart from glucagon, a better way, rather more simpler way, is the mixed meal stimulation test. It takes more time, but it's a better way of doing it. So again, you measure the fasting blood sugar and the C-peptide in the morning. And what I'm trying to tell you is the protocol which we use in our practice. This protocol has been seen with CMC Vellore also. So there's a published protocol in one of the papers from CMC Vellore, right? So I don't take original credit for that. But this is the protocol that we practice in our hospital. So you measure the fasting blood sugar and the C-peptide. You give liquid mixed meal, which is either Sustacol. I'll tell you what Sustacol is, or if you do not have Sustacol, you can use Ensure Plus powder, in which you give 6 scoops in 200 ml of water. And after 90 minutes, you measure the random sugar again, post 90 minutes of stimulation, and the C-peptide value post the stimulation. So this is the protocol for mixed meal stimulation test. Now, Sustacol is the standard protocol, which Sustacol is some sort of a protein which comes from Nestle. But Sustacol is not easily available in India. So because it's not easily available, you can use Ensure Plus powder. But again, now with online pharmacies, you can order Sustacol also. It's not very difficult to order that. So if you want to do it with the original protocol which was described, you can use Sustacol. But otherwise, if not, you can use the Ensure Plus powder also, which is from I believe Abbott. So you can, that's very easily available in the market. Okay. So in terms of percentage, a normal stimulation of C-peptide is 150 to 300 times over the basal value, right? So it's about 3 times or the basal value, right? And this is again a good way of interpreting. Okay, now what we have done in terms, another innovation that we have done, and we are using this, we have not published this so far, but this is something which we routinely practice now. And we have made a grading system for scoring of mixed meal stimulation test in our hospital. In fact, we have published an abstract for this, but we're not published the paper. Unfortunately, we're not gone down to write the full paper. So here what we do is we give a score based on the fasting and the post-stimulation C-peptide value. And based on the score, we do the interpretation, right? So you can see here, you can in fact take a screenshot of this. I'm not going to do every point, but what I'm trying to tell you is if the fasting C-peptide value is less than 0.24 nanogram per ml, the score value is more than 5. Score value is 5, and post-stimulation, if it is less than 0.6 nanogram per ml, it is 5. Same way, if the post-stimulation is more than 3.3, or like I said, a random or a stimulated C-peptide more than 3 almost rules out type 1 diabetes. And again, if the fasting is more than 1 nanogram per ml, again you think of less likely that the patient is having type 1, right? So these are the scoring system. You put this data, and if the score is more than or equal to 5, it is suggestive of type 1 diabetes. If the score is between 3 to 5, it is suggestive of type 1, but you still need to interpret with caution. If it is 0 to 3, it is unlikely to be type 1, but you again need a close follow-up. And if it is 0, it is not type 1, right? Here I'm not talking about the C-peptide value, I'm talking about the score, right? So the score value is more than 5, it is suggestive of type 1, right? And how do you calculate the score? Do the mixed meal stimulation test and put the values according to this table, and then you get your score, right? Now, this is a study where they looked at the C-peptide values in total, and you can see I made some markings, right? So 3, 6, and 9, right? These are the markings. So you can see if you take fasting C-peptide, most of these patients have C-peptide less than 3. In fact, most of these patients will have C-peptide less than 1, right? That is almost for certain, right? Though, of course, there's no one marking, but one marking will be somewhere over here, right? So if you see, almost most patients have fasting C-peptide values less than 1. And then if you talk about stimulated, here they've done glucagon stimulation. Well, interpretation of glucagon stimulation will also be the same. So if you see glucagon stimulation, you can see again that most of the patients with type 1 diabetes have glucagon value, stimulated value less than 3 nanogram per gram, right? So broadly, I already told you this, right? Most patients will have a fasting C-peptide in type 1 less than 1, in fact less than 0.6 to be very precise, and post-stimulation value will be less than 3 nanogram per ml. Okay, so this is the broad interpretation. You can, if you forgot what I told you, you can go back and listen to this presentation again, and you will get the thing again. Okay, so now there is one more thing which, if your patient is having type, that the patient is having type 2 for sure, but you want to convince your patient that the patient needs insulin, or the patient has long-standing diabetes and requires multiple doses of insulin. One useful test is a post-stimulated or a random C-peptide value. I told you how to interpret random C-peptide. So if you have a post-stimulation or a random C-peptide value less than 3 nanogram per ml, this patient is very likely, even though the patient may have type 2 diabetes, the patient is very likely to need multiple doses of insulin therapy instead of basal alone, right? So such patients, you should consider a MDI therapy in your practice, right? Now, another very useful thing where you use C-peptide is interpretation of hypoglycemia. Like I said, I'm not going to go into too much detail about hypoglycemia interpretation, but that's a separate topic in itself. But the thing is, you need to take what is known as a critical sample, right? So you take a critical sample, and critical sample is the one in which you, when the blood glucose is less than 55 milligram per deciliter. So you're taken the blood sample when the glucose is less than 55 milligram per deciliter. And at that point of time, you measure the C-peptide. And if the C-peptide is more than 0.6 nanogram per ml, that means that the time of hypoglycemia, the body's insulin production is not suppressed. And this is what is known as insulin mediated or insulin dependent hypoglycemia. If the value is negligible, if the C-peptide can hardly be measured when the patient is having hypoglycemia, it is likely to suggest other cause, that is insulin independent cause of hypoglycemia, right? So this is something which is a very useful thing. Perhaps in future, when we have another Hormone India Mahakumbh, we can probably discuss hypoglycemia in more detail, non-diabetic causes of hypoglycemia. Right. Now, another way of measuring C-peptide, like I said, is taking a urine sample. So instead of taking a blood sample, you can measure the urine sample. Now, one standardized protocol which has been developed, it has been developed by Exeter, that is urine C-peptide to creatinine ratio. Now, this is very useful because you do not have to take a 24-hour sample, you can take a spot sample. So you take a random urine sample in a Boricon container, generally post-prandial, post 2 hours after a meal. And this sample can be stable for up to 3 days. So again, you can send it to some lab, right, which can do the assessment. And the measurement is done in nanomoles per millimole, right? It's done in nanomoles per millimole in terms of the testing. Now, this test, unfortunately, is not available in India, but if you have access to Exeter, you can send this test to Exeter. Like I said, the urine sample will be stable for, if you use a Boricon container, it will be stable for almost 3 days. So perhaps, fast courier, you can probably send it. Now, how to interpret this value? Less than 0.2 nanomoles per millimole is suggestive of severe insulin deficiency. 0.2 to 0.6 is intermediate, and 0.6 greater than or equal to 0.6 is suggestive of reasonably good insulin secretion endogenously. Right now, this Exeter people have actually proven, and they said that they again used a criteria for MODI. In fact, Exeter is famous for genetic testing for diabetes, and this is why they have developed this assay. And they say that it is very useful in differentiating MODI from type 1, especially in children with various suspecting MODI. And if the UC-PCR is more than 0.2 5 years after the diagnosis of diabetes, it is very likely it rules out type 1 diabetes, and it is 95 sensitive in ruling out type 1 diabetes. So this is where the UC-PCR is useful. And again, it is, you can interpret it just like you interpret the C-peptide in the blood, which we discussed, but this is in urine, so this is another way of doing it. But I have not used this in my practice, so I have less knowledge of this. In fact, the other test which I talked to you about in terms of the random C-peptide and mixed field stimulation, we do it almost every day. So it is something which I'm much more familiar with this, but the urine is also an option. I hope this test is now, I hope easily available in India also in future. Okay, another useful place where C-peptide can be used is, and there are just a few papers on this, that is predicting the chance of remission after bariatric surgery. So one study, they've done a fasting C-peptide value, and they found that fasting C-peptide, like I already told you previously, that fasting C-peptide interpretation, you have to do it very carefully. But in this test, they use fasting C-peptide, and they found that those patients having fasting C-peptide more than 6 nanogram per ml have 90% more chances of remission after bariatric surgery, especially a Roux en Y bariatric surgery. So this is something which perhaps your bariatric surgeons can use in their practice, especially when they want to consider, or when they want to give the promise of the patient going into remission of type 2 with bariatric surgery. Okay, now let's talk about some pitfalls of C-peptide measurement. Now, C-peptide, you have to be very careful when you interpret in case of patients with renal failure, especially chronic kidney disease. So C-peptide is excreted by the kidney. C-peptide may be falsely elevated in patients with renal failure, and hence you should be very careful in interpreting the values in these patients. Again, another important thing, sometimes type 1 patients can have normal C-peptide. What are the situations in which a type 1 patient can have a normal C-peptide? If you have an obese type 1 patient who is recently diagnosed, this patient can sometimes have a erroneously normal C-peptide because of insulin resistance which they are having. Secondly, also, you can have a normal C-peptide when you have a recently declining insulin levels, like in case of COVID patients. So again, you have to be very careful. And thirdly, like I said, in renal failure patients also, sometimes type 1 patients can have a quote unquote normal C-peptide. So you have to be very careful while interpreting in these situations. And again, you need to talk to your endocrinologist for more information on this. Sometimes a newly diagnosed patient with type 2 can have low C-peptide value. It is quite possible. This especially happens when you are testing for C-peptide when the patient is in a glucotoxic state. I already told you that when you want to test for C-peptide, make sure that the patient is not glucotoxic. Do not measure C-peptide when the patient is admitted for ketosis or when the patient's blood sugars are very high, because you'll get false low values, and you get a false low value, you will interpret this patient in a wrong way, and this label unfortunately gets stuck to the patient for a long time. Okay, and one final clinical pearl I'd like to tell you. Now, A beta classification, this is what I use more in practice now instead of type 1 and type 2, is a better rubric for classifying diabetes than the original concept of type 1 and type 2 diabetes. In fact, it is, more and more, we are going towards personalized medicine, and these sort of sub classifications are better than the original classification of type 1 and type 2. Now, when you talk about A beta classification, what we say, A is for autoimmunity and B is for beta cell function. Autoimmunity is tested using the antibodies, that is CAD antibody or ZNT8 antibody or IA2 antibody, IAA antibody. These are the antibodies you test for autoimmunity, and B is the beta cell function, and this helps in assessment of the C-peptide, which we already talked about. Now, A plus, that is autoimmunity is present and beta cell is negative. This is the garden variety type 1. Whereas autoimmunity negative and beta cell function is preserved, this is suggestive of type 2 or MODI. This is something you should understand. And a clinical pearl here is that of these two, The beta cell function assesses the current status of the endogenous insulin production, whereas autoimmunity assesses the future beta cell status. So this is something which can be helpful. So if the patient is autoimmunity negative, that means perhaps it could mean that there is no further progression of the beta cell deterioration, whereas the C-peptide value tells you the current status of the patient's clinical picture. Right. So let's summarize and some key take-home messages. So what is C-peptide? C-peptide is a residual product when proinsulin is broken down. It is released in equimolar concentration as insulin. It has a half-life which is longer than insulin, and its main purpose is to assess for the beta cell reserve. A random C-peptide is useful. When you are trying to interpret random C-peptide, your simultaneous glucose value should be between 140 to 200 to get the most optimal result. If the random C-peptide is less than 0.6, it is suggestive of absolute insulin deficiency and more likely to suggest type 1. Whereas if the random C-peptide is more than 3 nanogram per ml, it is suggestive of, it rules out absolute insulin deficiency and it's more likely to suggest a type 2 diabetes or MODY. Again, the gold standard is of pancreatic beta cell assessment is stimulated C-peptide, and stimulation can be done using either Ensure Plus or Sustacol, that is mixed meal stimulation, or glucagon stimulated test. We have developed a scoring system for that, and if the score is more than or equal to 5, it is suggestive of absolute insulin deficiency or type 1 diabetes. So I thank you for a patient listening. Like I said, my thinking in medicine is 1 + 1 is equal to 2, right? We need to develop better tools for ensuring that we do more precise treatment, more precise diagnosis, and my whole life's entire goal is to develop these systems which can help better management of patients with not only with diabetes but with other endocrine diseases as well. And in this regards, we are trying to develop some tools. Endo AI, it's available. It's an AI tool where it can answer questions regarding endocrine, right? Or in fact, it does it better than, if you ask me a question, Endo AI will be able to answer that in a better way. We have notes in endocrinology, which is available as an app and also available on the website called endocrinology.co.in. You have this entire notes on C-peptide, what I talked to you about, it's available as a note in this. And we have also developed something called diabetology.co.in, which you're developing, which I already showed you the screenshot of how you can classify the patient and get better treatment options for patients with diabetes mellitus, right? Especially newly diagnosed diabetes. So I thank you for a patient listening and would be happy to take questions if you have time.